Hello, my name is Dr. Mona Panahi, a foundation doctor in GI surgery. This video is about nutritional support. We will briefly cover causes and prevention of malnutrition and the types of nutritional support you may see, and parenteral and enteral nutritional support. However, I want to focus the talk mainly on tips for an FY1 on surgery and what your role is to ensure a patient's nutritional needs are met. Causes of malnutrition are multifactorial. The stressful surgical environment itself places patients at risk. Patients have greater nutritional requirements for wound healing and are at a disadvantage following surgery because they often suffer with post-operative pain, and when we prescribe strong analgesia, they develop nausea. So because GI patients, by the nature of their conditions, are likely to have malnutrition, dietitians will often visit wards, and they play an important role in assessing patients' needs. As a doctor, you'll need to work with them and consider. As a doctor, you will work alongside dietitians and consider different feeding routes for patients, prescribe oral nutritional replacements and supplements when blood results are deranged, and consider prevention, for example, prior to elective colorectal surgery as part of the enhanced recovery after surgical pathways, as part of the enhanced recovery following surgical pathway, non-diabetic patients are prescribed high-calorie drinks. And these all help to improve post-operative outcomes. And these all help improve post-operative outcomes. So an example of a patient you will see on the lower GI ward is this 76-year-old lady. As an example of a patient you'll see on the lower GI ward is our 76-year-old lady here. A few days down the line from an emergency laparotomy and bowel resection, she's been transferred to the colorectal ward from acute surgery. No stool fluid or wind has passed into her colostomy bag. When she has slowly tried to rebuild her diet with initially sips, then soup and sweet, but this has been vomited back up. Which of the following is the most appropriate nutritional support to consider? IV supplementation, for example, with 2 litres of normal saline and added potassium chloride, with maybe a bag of dextrose. Nutritional drinks such as 40 sips, a nasogastric tube, gastrostomy feeding, or total parenteral nutrition IV. We'll discuss the indications for these and come back to the answer. There are different types of nutritional support used. An NG feed passes from the nose to the stomach. They're used short-term over a few weeks in patients who have inadequate or unsafe oral intake and a functional GI tract. They're often seen on medical wards in patients with dementia or stroke causing bulbar palsies. Orogastric tubes are similar, but they're more appropriate in head injuries such as with a basal skull fracture preventing an NG going down, and very short term because they're often poorly tolerated and make you gag. They're not very nice. They're very short term as they're poorly tolerated and then cause gagging. They cause gagging and are often poorly tolerated. For upper GI and acute surgery, you may see gastrostomy tubes or jejunostomies. You may see on upper GI and acute surgery, you'll see nasojejunal feeding to bypass the stomach, for example, in pancreatitis or following a gastrectomy, where the lower GI tract is intact. Longer term, these patients could have gastrostomies or jejunostomies in place. Because this talk is mainly focused This talk is mainly focused for patients starting colorectal surgery, and there, because you don't have a functional lower GI tract, you'll usually use partial peripheral nutrition or TPN, total parenteral nutrition. So in lower GI surgery, you will usually see, in lower GI surgery, you often don't have a lower GI tract. Lower GI surgery will often have TPN. Patients on lower GI surgery will often have IV supplementation with partial nutrition or TPN, partial or total parenteral nutrition. Patients on lower GI surgery will have partial or total parenteral nutrition. These are bags of white-coloured fluid that will be hung up beside patients on a drip stand. The fluid consists of a formula of glucose, amino acids, vitamins, electrolytes, minerals, lipids, and these all pass into patients via IV and completely bypass the alimentary canal. They're good for patients with ileus or in partial nutrition for patients who aren't meeting their requirements chronically. Going back to our lady from earlier, she would require TPN. You would hope that, a few days down the line from surgery, you would Going back to our lady from earlier, she will require TPN. The patient is in post-operative ileus, which is in post-operative. The patient is in post-operative ileus, common after abdominal surgery, and on a lower GI placement, you will certainly have patients with TPN on the ward. It usually takes a couple of days for patients to open their bowels or pass wind. However, after a few days of no motion, you need to start considering other feeding options. You would have hoped the patient would already be on fluids after surgery and having reduced oral intake, and nutritional drinks would be counterintuitive and likely be vomited back up. Nasogastric and gastrostomies wouldn't bypass the bowel, which is the issue here. TPN can be used short-term through a peripheral vein, but ideally a central access line is required. Peripherally, TPN can go through a cannula, but it irritates the vein and thrombophlebitis quickly develops. So if you can't see the patient progressing through their ileus, you should consider booking for a central line. You should consider booking for a central access, or at least have an up-to-date coagulation screen on the next day's bloods in preparation for one. TPN are higher risk preparations because the products often can't undergo sterilization. If you're administering TPN via a line, the risk of sepsis is greater, and patients who spike or have increased white cells need to have peripheral blood cultures through a new bleed and also line cultures. And if you think the cause of infection is likely to be the line, you need to stop using it. Patients started on TPN are also at risk of Patients started on TPN on the wards will need daily blood tests. These are usually sent first thing in the morning in time for pharmacy to calculate their nutritional needs. And the proportion of electrolytes the patient requires. The bag then runs slowly over the course of the day. Don't take TPN, make sure you take TPN bloods from the other arm, the other side to the TPN. Make sure you don't take TPN blood from the arm it's going into. We had an incident where a new phlebotomist took TPN bloods upstream to the peripheral cannula, and we had a frantic call from the path lab for a potassium of 8. We rushed in, ECG machine, blood gas syringe in hand, To see the patient happily scrolling away on her phone, a repeat blood showed that the potassium was normal. So because the TPN contents are of higher electrolytes, because the TPN bag contains a higher electrolyte content, make sure to use the other arm, and make sure you don't take blood upstream from where the line's going through. For patients on longer term TPN, they're at risk of cholecystitis from bile stasis due to disuse of the GI tract. Liver function tests would be required because a major source of calories is linoleic acid, which can cause fatty liver disease. But again, these are longer term and less likely to be seen on the wards. Refeeding syndrome is also a risk, which is why daily bloods are so important. Importantly, patients need strict fluid input and output measurements. Importantly, patients need strict input and output measurements of their fluids. If a patient has increased losses, such as a high output stoma, they may lose a lot of water. TPN contains a patient's maintenance fluid based on their BMI, so don't prescribe additional fluids. Make sure you don't prescribe additional fluids unless there are losses. If you are prescribing fluids, make sure you only prescribe saline. If you're concerned about a patient's electrolytes being very deranged, speak to pharmacy or the nutrition team. You don't want to overload patients with too much potassium from their nutrition bag as well as in their IV fluids. You don't want to overload patients with, for example, with a high output stoma and low potassium on a blood test. You don't want to overload patients with potassium that they're receiving both through their TPN line and through an IV bag. So speak with pharmacy if you're concerned. If it's a moderate electrolyte, if the derangement is only mild, usually this would be corrected by the TPN bag. Strict fluid input and output measures are required. Importantly, if a patient has increased losses such as a high output stoma, they may lose a lot of water, but TPN contains the maintenance fluid a patient needs. So don't prescribe saline if they don't appear clinically dehydrated because you will overload the patient. Again, if the electrolytes are mildly deranged, don't add potassium into the bag because this will likely be corrected in the TPN. Discuss it with pharmacy if you have any concerns. In summary, malnutrition is very common in general surgery and dietitians will be your friends on the ward. Patients on TPN will require their medications switched to IV because there's an issue with the absorption. They need line access, so either a peripheral cannula, and if that doesn't look like and if the ileus doesn't appear to be resolving, you should consider a coagulation or request forms for a central access. You should consider a coagulation screen for when your senior decides to escalate to a central access. They'll need daily bloods to measure their electrolytes, and they will need daily bloods taken from somewhere other than upstream to their TPN line, and you need to replace fluid losses using saline, and only replace fluid losses using saline. That's a little bit of extra reading. And please subscribe to the channel to rate, and please subscribe to the channel. And please subscribe to the channel. And please subscribe to the channel.